Hello and welcome. I'm Dr. Christine Human, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled, As We Age, Considering the Impact of Renal Impairment when Choosing an HIV Pre-Exposure Prophylaxis, or PrEP, formulation. Today's program is supported by an educational grant from Gilead Sciences. I'm an assistant professor of clinical medicine in the Department of Medicine and Division of Infectious Diseases at Indiana University School of Medicine. I'm also medical director of the Bellflower Clinic and STD control program for the Marion County Public Health Department in Indianapolis, Indiana. Our learning objective today is to apply clinical trial data and other available evidence to decision-making for initiation of PrEP. Let's start by meeting Matthew. He's a 53-year-old Hispanic man who has sex with men. He presents to clinic today for a quarterly checkup. Matthew's BMI is 28. He has type 2 diabetes that's managed with metformin and also hypertension that's managed with lisinopril. He takes occasionally some over-the-counter ibuprofen for headaches. He does not smoke tobacco, but does smoke cannabis about 4 to 5 times a month. And he consumes 2 to 3 drinks per week. Let's go ahead and watch the clinical encounter with Matthew. Hey, Matthew, so nice to see you. Is it just me or does it seem like these visits are flying by? I know they're quarterly, but it seems like it's every month the way time's flying.
Yes, Dr. Human, I agree. It's been a crazy time at work for me, which makes it seem like it is flying. Although at the same time, I need about 5 more hours in the day.
Well, I hope you've taken some time off to recharge. Is there anything new or different that I need to know about?
Hopefully my labs and blood pressure are okay. I never really shared, but in addition to work, the last 6 months have been stressful. And plus I haven't been really great about self-care. But I'm starting to shake it off and determined to be better about my eating habits and overall outlook.
Well, I'm so sorry to hear you've been going through a rough patch.
We've known each other a long time. So just to let you know, Pete and I split up. It was hard, but it was time. I'm starting to think about putting myself out there again. Part of me is excited, and the other part is,
Yeah, well, I'm glad to hear you're thinking about putting yourself out there again. You have been in a mutually monogamous relationship for a long time, so you haven't had to worry about HIV or other STIs. But as you're thinking about new partners, we should start to think about which prevention strategies might be best for you.
Really? Come on, you know me, I'm not a wild child and gonna go crazy. Plus, I'm very picky.
It's important to know that there may be a low perception of HIV risk among older adults. Much of the data on risk factors for acquiring HIV has focused on younger populations, such as young men who have sex with men and persons with injection drug use. There's also a perception of HIV as an illness for younger people. For example, one study found that older adults are 1/6 as likely to use condoms during sex and 1/5 as likely to have an HIV test compared to people in their 20s at risk for HIV infection. Another study showed that older sexually active women may view condom use primarily as contraception rather than as protection from HIV and other sexually transmitted infections. Unfortunately, because of this, older adults may be missed in targeted HIV prevention strategies that are focused on younger populations. However, in 2018, 17% of new HIV diagnoses were among people 50 years of age and older. And of these, 35% were diagnosed with late-stage disease. This is concerning for a variety of reasons. It can lead to increased morbidity and mortality, risk of further HIV transmission in the community, increased healthcare costs, and potentially decreased virologic response to antiretroviral therapy for the individual. Let's go back to our visit with Matthew. I know you're selective, but anytime you're having a sexual encounter with someone you don't know and you don't know their HIV status, there is some risk involved. Condoms are good at preventing HIV and STDs, but we also have another HIV prevention technique called PrEP.
You're right. I do need to start thinking a little differently. It's been a while. Of course, I've heard about PrEP, but I've never really paid close attention to know much about the details.
Well, I'm happy to provide more information about PrEP today. If you take PrEP every day, it's about 99% effective at preventing HIV infection. Side effects can occur, but they're usually mild and they go away over time. Because you do have diabetes and hypertension, we have to consider your kidney function as we're choosing the right formulation for you. And before we get started on PrEP, we typically do some lab work. That would include an HIV test, STI screening, hepatitis screening, as well as some tests about your kidney function. I was planning to do a test for your hemoglobin A1C anyway today. So if you're interested, we could go ahead and do all these labs for PrEP as well.
Okay. I haven't had anything to eat today, so I can go do that right now.
Great. Why don't you head on over to the lab and I'll call you back at the end of the day with your results.
Okay, thanks.
What in Matthew's metabolic panel would be of interest related to both his diabetes and PrEP? What in Matthew's medical and social history may impact your decision about PrEP? There are a lot of different factors to consider when prescribing PrEP. One of them is age. Age is associated with increased medical comorbidities that may increase risk for decline in renal function. Some of these medical comorbidities include diabetes and cardiovascular disease. In the United States, diabetes and hypertension are the leading cause of kidney failure, representing 3 out of 4 new cases. It is also important to note that the prevalence of diabetes is higher among Black, African American, Hispanic, and Latinx persons than it is among non-Hispanic whites. Another consideration is substance use. Substances such as methamphetamines, cocaine, opioids, cannabis, and alcohol have been shown to have a negative effect on renal health. Continuing on with substance use, it's also been shown that tobacco use may cause tubular dysfunction and glomerular sclerosis, and that can lead to progression of kidney disease. And another thing to consider is that higher prevalence of chronic disease may mean more polypharmacy and the need to consider drug-drug interactions. For example, you may need to consider whether or not the patient is on ACE inhibitors, ARBs, some antibiotics, chemotherapies, NSAIDs, or medications for hepatitis C. Now we'll return to our visit with Matthew. Hey Matthew, how was your day?
Not too bad. Everything check out okay?
It did. Your HIV, STI, hepatitis tests, those were all negative. Your hemoglobin A1C is looking pretty good. Your kidney function's a bit reduced, but it's stable compared to your prior lab test.
Does that change the strategy?
So Matthew's lab work has returned. His STI screening is negative for HIV, syphilis, and gonorrhea and chlamydia testing at 3 sites was negative. So that was pharyngeal, urine, and rectal. His hemoglobin A1C has returned at 7.2. Creatinine is 1.6 milligrams per deciliter, and his estimated creatinine clearance is 67 milliliters per minute. What HIV prevention strategy would you recommend for Matthew? Now we will review some of the clinical trial data from the DISCOVER trial. The DISCOVER trial is a multinational, randomized, double-blind, active-controlled, phase 3 non-inferiority trial that compared emtricitabine and tenofovir disoproxil fumarate, or FTDF, to the combination of emtricitabine and tenofovir alafenamide, or FTAF. And this was studied in cisgender men and transgender women who have sex with men. In the FTDF arm, there were 2,694 participants, and in the FTAF arm, 2,693. The primary outcome of interest in the study was incident HIV infection, and they also looked at a number of secondary outcomes, and these were measured as a percent change from baseline. The secondary outcomes included hip and spine bone mineral density, urine beta-2 macroglobulin to creatinine ratio, retinal binding protein to creatinine ratio, clinically significant elevation in urine protein to creatinine ratio, and changes in serum creatinine measured by eGFR by Cockcroft-Gault formulation. These figures compare HIV incidence in the FTAF and FTDF groups at 48 and 96 weeks. The bar graph on the left shows FTAF in blue and FTDF in pink. At 48 weeks, there were 7 HIV infections in the FTAF group, and that was compared to 15 in the FTDF group. And then at 96 weeks, there were 8 infections in the FTAF group compared to 15 in the FTDF group. The figure on the right shows incident rate ratios at 48 weeks on top and at 96 weeks on the bottom. At 48 weeks, the incidence rate ratio, which is the incidence of HIV in the FTAF group divided by the incidence in the FTDF group, was 0.47 with a 95% confidence interval of 0.19 to 1.15. At 96 weeks, it was 0.45 with a 95% confidence interval of 0.23 to 1.26. For both of these measures, the upper limit of the 95% confidence interval was less than the pre-specified non-inferiority margin that had been set at 1.62, and the upper limits of both measures at 48 and 96 weeks were below this. This means that FTAF was found to be non-inferior to FTDF. 2 of the secondary outcomes in this study were changes in serum creatinine and changes in estimated GFR. These graphs show these outcomes at 48 weeks. First, looking at the left, FTAF is represented in blue and FTDF in red. Both groups started with the same baseline median creatinine values of 83.1 micromoles per liter. At 48 weeks, the FTDF group had a 0.88 increase in creatinine, and the FTAF group had a 0.88 decrease in serum creatinine. And this was a statistically significant difference. The figure on the right shows eGFR. Again, at baseline, these measures were pretty similar. So the baseline eGFR for FTAF was 123 milliliters per minute, and for FTDF, 121 milliliters per minute. At 48 weeks, the FTAF group, represented in blue, had an increase in GFR of 1.8, and the FTDF group, illustrated in red, had a decrease in eGFR of 2.3 milliliters per minute. And this was, again, a statistically significant difference. These graphs are looking at the same outcomes of creatinine and eGFR, but now we're looking at the results at 96 weeks into the trial. Serum creatinine, shown on the left at 96 weeks, had decreased by 0.88 in the FTAF group in red, and by 1.77 in the FTDF group. And then looking at the graph on the right, looking at eGFR, we see that in the FTAF group, the GFR increased by 3.7, that's illustrated in blue, and the FTDF had a decrease by 0.4 milliliters per minute in eGFR. And both of these differences at 96 weeks were also statistically significant. In conclusion, the DISCOVER trial showed that FTAF was non-inferior to FTDF in preventing HIV infection, and also that it had less impact on creatinine and eGFR as compared to FTDF. Now, let's go back to Matthew and discuss his options for treatment for PrEP. Your kidney function's a bit reduced, but it's stable compared to your prior lab test.
Does that change the strategy?
Not so much change, but it definitely gives us direction on which would be the better formulation of PrEP to choose. Right now, there's 2 medications that have been approved for use as PrEP. One is a combination of 2 drugs. One is called emtricitabine. The other one is called tenofovir disoproxil fumarate, or we call that FTDF for short. And the other medication is FTAF, and that one's a combination of, again, emtricitabine, but the other medication in it is tenofovir alafenamide, a different formulation of the tenofovir. Recent data have shown that they're both very effective at preventing HIV, but the FTAF formulation may be a better choice for you because it's less likely to further decrease your kidney function.
Okay, well, that makes sense. Anything I need to know about side effects or how I take it? I know it is once a day, which is great. Is this something that I need to be hyper diligent about taking?
Some patients do experience side effects with this. Common ones are diarrhea, nausea, headache, fatigue. Please call me if you're having any side effects that are very bothersome, or if you have any that are lasting more than a week or so. Adherence is very important, as you mentioned, to help prevent you from getting HIV infection. It also helps protect you from resistance if you were to miss doses and become infected with HIV. And remember, PrEP is only providing protection against HIV. You'd still need to use condoms to help prevent any other sexually transmitted infections.
Got it. Fortunately or unfortunately, I'm in the habit of taking pills, so that part should be good. What about monitoring? Do we need to do anything on a regular basis?
Which of the following is recommended by the CDC for follow-up testing and monitoring for an individual prescribed PrEP? This chart outlines PrEP follow-up visits as recommended in the CDC guidelines. After initiating PrEP, it's crucial to screen for HIV infection every 3 months. Serum creatinine and estimated creatinine clearance should be measured at 3 months after initiation and then at least every 6 months thereafter. Every visit is an opportunity to provide support for medication adherence and behavioral risk reduction. We also do additional screening at these visits for various groups. So for men who have sex with men, we consider screening for bacterial STIs as frequently as every 3 months. For others, this could be every 6 months. For women who could become pregnant, it's recommended to test for pregnancy every 3 months. And for persons with injection drug use, it's recommended to assess for access to clean needles and syringes and drug treatment services at every 3-month visit. There can be many barriers to PrEP adherence. Some that have been described include substance use, side effects of the medication, poor health status, so potentially some of those comorbidities I talked about earlier, perception of having a low risk of HIV infection, the inconvenience, and that can either be of taking a pill every day or needing to go to doctor's visits often, social stigma related to taking HIV prevention medication, as well as social determinants of health. There are also several factors that have been shown to facilitate PrEP adherence. At the individual level, this could be setting phone reminders, it could be using a pill box, tying taking the medication to a daily activity such as brushing teeth, and also the individual's perceived risk of acquiring HIV and their perceived benefit of taking PrEP. Providers can support adherence by building rapport with their patients. They can also make sure their counseling sessions are tailored to the individual and continue to provide counseling at every follow-up visit. And at the societal level, family and peer support can be helpful, as well as having payer assistance. So let's summarize our discussion from today with SMART goals. That means specific, measurable, attainable, relevant, and timely. That is, these are the things that I hope you will take away from this presentation and be able to apply to your patients. So I hope that you'll be engaging older adults who are at risk for acquiring HIV and discussions about HIV prevention strategies, that you'll be able to evaluate medical comorbidities and risk factors in older adults that may impact treatment decisions when choosing a PrEP formulation, that you'll be able to assess long-term clinical trial data for comparing FTDF to FTAF related to incident HIV infection, as well as differences in serum creatinine and EGFR, and that you can provide patients with resources, tips, and strategies for optimizing adherence to PrEP. Today's CMEO briefcase is part of a 3-part series of case-based activities that can be found on the Infectious Diseases Hub at CMEOutfitters.com. I hope you'll check out the other 2 activities in the series as well. The Infectious Diseases Hub has these activities and many other activities on HIV. CME Outfitters also has an HIV patient education hub with a number of excellent resources, videos, and a whiteboard to share with your patients. Thank you for joining me today. Don't forget to complete the post-test and evaluation. As a reminder, this activity is also available for ABIM Maintenance of Certification credits. Please stay safe, and thank you again for providing the best care for your patients.